Is it wise for the Republicans to be talking about repeal and replace after these 2 Supreme Court rulings and after 5 years of the health care plan being in place?
Well, first of all, thank you very much to the Washington Post for joining us at Jones Day for this. It's really great to have you here. What I would say about that is that it is wise for Republican candidates to talk about repeal and replace for any number of reasons. Tomorrow night's debate will actually provide a forum for showing ultimate contrast between a Republican position and whoever the Democratic nominee is. It's an unpopular program. It's a program that is not working terribly well, and with the inflationary costs or the increased costs of the program that are coming, it will provide an awfully good platform for Republicans to be able to contrast themselves. It's the main surrogate issue for the size of government issue that will be predominant, I think, in the campaigns, in the general election campaign. And it's an opportunity for all our candidates to be able to point out the more ways that we can help provide health care as a surrogate for government solutions.
It seems awfully hard to, well, of course, the debate, each person has about a minute to respond to any question. It seems pretty hard to lay out a plan for replacement. And I think that's one of the big obstacles for all of those candidates. What is it that you would be listening for from any of these? I know you're advising Scott Walker. What have you suggested that he do in this regard?
Without talking about any specific candidate, I think you'll see.
Sorry about that.
I think you'll see all the candidates wanting to be able to talk about how they can provide more affordable coverage to as many people, to basically get the marketplaces working. There'll be solutions like providing insurance across state lines. The individual mandate that Michael can talk about very articulately will, of course, come up as an issue. And it's all about the solutions that can come from a more conservative approach.
I'm going to skip Mike for just a second because I want. Now I'm going to come back to you, but I want to get this over to you, Toby, because you've actually had to implement the ACA. Let me ask you first, though, did you support it from the beginning?
Well, we knew that healthcare had to change. And right now it is the law of the land, and we are implementing it as fast as we can. That has substantial ramifications for us. We know that we're not going to get paid as well as we did for the things we do. So we have got to take probably 15 to 20% out of the cost of running the Cleveland Clinic, which we are well on the way to do that now. And we are expanding our coverage, and we're looking after more people, and I think we're delivering better quality.
Well, you say you're delivering better quality, but the costs are going up. And what would that mean in terms of your forecast? I mean, we're looking at higher and higher costs as we move along, aren't we not?
Well, I guess that's a very good question. When you really look at it, there's really 3 things that the Affordable Care Act attempted to do. First of all, they wanted to improve quality, they wanted to improve access, and they wanted to decrease cost. And I think you would have to say that there are 13 million more people covered. 90% of the people who are less than 65 are covered, so that the access has improved. Quality is really a gray zone. The number of quality metrics that there are out there, most of them have remained flat over the 5-year period that we're talking about.
What does that mean, quality metrics?
Well, the number of infections you have, the number of urinary tract infections, the number of ulcers, et cetera. And we're now reporting 123 quality metrics to the federal government each year. So there have been some changes. There's a decrease in readmissions to the hospital, and that's been driven by really 2 things. One, transparency, and the other, financial incentives. And we're seeing a decrease in bloodstream infections. Now, on the cost issue, it's interesting that is probably the most controversial. Last year, healthcare inflation was at an all-time low of 2.6%. The reasons for that, I think, are very debatable. If you take, for example, along the economy, certainly had an effect with a lot of people not going to get health care. High deductible insurance also played a part in it, with people being reticent to sometimes go and get care, and more of the responsibility laid over on the individual. There was also transparency around cost, which is coming up from both, and finally the ACA and all of us who are providers looked for ways that we could begin to prepare ourselves because we knew we were going to be paid less. Whether this is going to continue or not, I think, is the real question. The OBM says that the inflation is going to continue to go up as more people come on board and as the population ages.
Well, to that point, even though, I mean, forgetting inflation, the population aging is huge, especially with these chronic diseases that are so expensive to treat. As just one example, I recently attended the Alzheimer's Association meeting and was told that by mid-century, 16 million Americans would develop Alzheimer's, and that's a huge number. And the cost of that, there's virtually no treatment, and at this point, no way of preventing. So how do you cope with those kinds of numbers? And that's just one disease. I mean, how do you adapt this to those costs? I mean, we're not really...
Yeah, so let me give you even a more terrifying data on that.
Oh, good.
I thought you'd like this. If you get to be 85, your chances of having Alzheimer's is 1 in 3.
When you reach 85? When
you reach 85. Terrifying, and that has a whole social and economic effect on society, which is enormous. Now, what we're doing right now is we're trying to look at how we can standardize care to make it more efficient, but you're not going to be able to just drive efficiency. You're going to have to actually reduce the burden of disease, and the way you begin to reduce the burden of disease, for example, is with obesity and smoking. Obesity right now, 2/3 of the United States are overweight.
I saw.
And it accounts for 10% of the healthcare costs in the United States. And that leads to diabetes, that leads to cancers, that leads to joint replacements, and the list goes on and on and on. So we are not going to be able to control the cost of healthcare in the United States until we begin to deal with these things that wind up causing chronic diseases. And by the way, Alzheimer's is one of those things that also is affected by lack of exercise, et cetera.
All right, well, I want to come back to that point about how we make people more well and less inclined to eat delicious things. But Mike, to you, so what is your view of the repeal and replace? I didn't give you a chance to respond to that.
Well, to pick up on the 2 points that have already been made, I would think that in addition to basic Republican principles, the reason for the unpopularity of the ACA is going to be because of these increased premium costs. Most people are projecting a 20 to 40% increase next year for a variety of reasons, including the fact that the Act's subsidization of insurance companies is going to cease in 2016, and it's going to go up even higher in 2017. So in October of 2016, a lot of people are going to be affected in a very important way on something that they're really going to remember, which is they're going to be paying more premiums for a plan with a very high deductible, with a very narrow range of doctors to choose from, and probably being pushed out of a plan that they, in some cases, were not that unhappy with. So I think it presents a real opportunity for the Republicans to make a basic Republican pitch, which is that we should be empowering consumers, not bureaucrats in Washington. And the principal means of doing that will also reduce costs, because instead of buying these sort of very elaborate plans that the ACA makes you buy, you can get catastrophic insurance, you can buy it across state lines, you could have malpractice reform, and all kinds of things that, because of some market discipline and because of some rational means, you're not only going to be providing people with what they need, which is insurance tailored to them rather than to some unrealistic ideal, which is frankly designed to have healthy 30-year-olds subsidize unhealthy older people like me, because they're paying the same premiums without accounting for these kinds of efficiencies and real prognostications about your future health status. And if you could get that kind of reform in, it wouldn't be a dramatic change in the infrastructure. You could keep, for example, the exchanges. You just wouldn't make them based on subsidies being handed out from Washington. You might have to go to a situation where the consumers have more skin in the game. one of the reasons I think that healthcare costs have increased is because nobody really ever pays for medical providers. It's usually some third party, the employer or Washington or the Medicare, Medicaid system. If you had people thinking about it more conscientiously, not only in terms of the health to prevent going to a medical provider, but searching out the kind of medical needs they really have, that could drive costs down. And I don't think this is an ideological issue. I mean, I just think this is arithmetic. If we don't get on top of the health insurance costs in this country, it's going to drive out everybody, every kind of other initiative that you'd want. They're talking about $1 trillion in Medicare alone in 2022. So these 85-year-old people with Alzheimer's are really going to stop us from investing in anything that you want, more education, more missiles across the dynamic. So I not only think it's good politics, I really think it's good public policy. And the sooner we wait to deal with this problem, the longer we wait to deal with this problem, the more extreme it's going to be.
All right. So, Ben, you, when President Obama first was trying to sell the ACA, one of the things he promised was, he said that he would have preferred a single-payer system, but it wasn't politically possible at that time. So just switching parties here for a minute, do you think that Hillary Clinton is a closeted single-payer person and will have to come out of the closet in order to move a little bit left?
Well, one of the wonderful things about this campaign is she'll have to articulate her own position. Chris Cillizza, your very own Chris Cillizza, had a fascinating column in the past week or so that said it's been 179 years since a Democrat was elected for 3 consecutive terms, if you don't count FDR getting reelected 4 times. And so nothing screams third Obama term like Hillary Clinton having to take a position on Obamacare. There, I said Obamacare too. And so I'm not sure if she's a believer in single payer systems or not, but she's going to have to articulate the position. And the way she takes on the unpopularity of the ACA and deals with having to separate herself or embrace Barack Obama will be one of the great things to watch in the campaign.
So I want to go back to obesity as a national health problem. I think when we were speaking earlier, you said something about how the private sector was going to have to pitch in and sort of push people toward wellness. This sounds slightly spooky to me. How do you mean that?
Well, what we did is at the Cleveland Clinic, we decided we would begin to model what was appropriate health care. And so we stopped hiring smokers, which, by the way, is illegal. It is legal.
You cannot.
I checked with Jones Day to find out if it was legal or not.
How do you do that? How do you say if you smoke in your own home, then you can't work here?
No, we check them when they come in for nicotine as part of their drug testing when we hire them. So our smoking rate across the country is about 20%. Ours is 5%.
Because everybody wants to work at Cleveland Clinic.
Well, you know, the thing that, you'll laugh, the thing that we were worried the most about was the biggest smokers in the hospital are respiratory therapists. We said, how the hell are we going to ever hire any? So the second thing we did is we put on a big push about obesity. We changed the food in the cafeteria. We gave everybody free curves, free Weight Watchers, free access to our gym, free yoga. And ultimately, financial incentives in reducing their insurance, we've lost 500,000 pounds.
Wow, that's impressive.
5 million more to go.
How many have they kept off? So you're encouraging other companies to do this?
Yeah, I think that this is where it's going to come from. It's not going to come from government, I don't believe.
Yeah. We're running out of time, unfortunately. Let's just have one last quick question. If let's just assume ACA stays in place for the time being, if there were one policy change that could be made that the President and the Congress could agree on, what should it be? Each of you got an idea?
I'm going to go back to the theme I talked about before. If you eliminate these minimum health benefits and allow people not to buy catastrophic, instead of buying mental health, maternity, or contraceptive insurance that they really don't need, that could have a dramatic effect on insurance premiums